Welcome everybody to our webinar. We're hosting President of the AANP, Dr. Stephen Ferrara, hosted by us here at Zivian Health, as well as our partners at Gold Sand Friedberg, authorities in health law. It's my distinct pleasure to introduce you to my friend and colleague for over almost 2 years now, Stephen Ferrara. He's a practicing nurse practitioner with over 20 years of clinical experience. He also serves as the Associate Dean of Clinical Affairs and an Associate Professor at Columbia University's School of Nursing. He has experience in college, correctional, retail, men's, and occupational health. He was the president, or sorry, he is the president, excuse me, of the American Association of Nurse Practitioners today, and also the editor-in-chief of the Journal of Doctoral Nursing Practice. He was previously the executive director of the Nurse Practitioner Association for New York State for over 10 years. And during that time, a number of barriers to NP practice were eliminated, most notably the NP Modernization Act. This historic law, passed in 2022, eliminated the requirement for collaborative agreements between experienced nurse practitioners and physicians, and thus turned New York State into a full practice authority state. He's lectured at numerous conferences across the country, and Dr. Ferrara holds a passion for health technology and integrating evidence-based practice into our daily practice. So with that, I'd love to welcome you, Dr. Ferrara, to our webinar.
Yeah, thank you so much for hosting me today, and I look forward to our discussion.
Awesome. Well, I thought we could start with just a little bit of background. I'd love to learn a little more about what inspired you to pursue a career in healthcare in general, and specifically as a doctorally prepared nurse practitioner.
Yeah, so I had always thought I wanted to be in healthcare. I enjoyed the sciences, I enjoyed biology. So when I was figuring out what I wanted to be when I grew up, I wasn't sure in which capacity, but I knew I wanted to be in the sciences. So I had, I went to college. I was a biology major. And at that point in time, kind of was exploring all avenues. I looked into medicine, I looked into physical therapy, to pharmacy, and I'll have to admit, my aunt, who's a nurse, had been encouraging me the whole time to look into nursing, and I foolishly did not follow that advice at that point in time, and I found myself graduating. And not having made any following steps, right? So I said, okay, I'm graduated. I have this biology degree now. And I started to become more serious about what I wanted to do. I went on a few job interviews to work in a lab as a bio major, and that absolutely solidified the fact that I do not want to work in a lab. No disrespect to our lab friends, but was just not the environment that I wanted to work in. So quickly learned that, okay, healthcare is definitely the area I want to be. I became an emergency medical technician. At that point, I did some work on an ambulance. I became a medical assistant and worked at an ear, nose, and throat practice, all with the intention that I was going to go back to school. And at that point, I chose nursing. And very naively, as a 21-year-old biology degree graduate, I didn't know what nurses did. I knew of nurses. I had family members who are nurses, but I really was unfamiliar with the work that the nurse does. So once I became exposed to it, and as an EMT, and worked with nurses in the emergency room, I said, okay, this is absolutely where I want to be. I became aware of the nurse practitioner role, so I sort of had that as a goal. So I worked. I went to one of the because I had all the science prerequisites. I had that already, so I was able to do just the nursing portion, and became an RN. Worked for about a year and a half or so as an RN in med surg orthopedics, and was a heavy floor. I was always asked to help lift and turn patients, which was fine. But I what that solidified to me was that, and again, no disrespect to our friends who work in hospitals, was that the hospital environment was not one that I enjoyed. I knew that outpatient, typical office-based healthcare was where I wanted to be. So went on for my nurse practitioner, and then became a nurse practitioner. Did go back to school because at the time, this was in the year 2000, the DNP didn't exist. So I had worked for, I guess it was about 7, 8 years before I decided to go back and get that doctorate. And here I am.
So just I'm curious, like at Thanksgiving, does your aunt like hold it over your head that she told you this in the very beginning, or is she like, "You're welcome, you owe me"?
Absolutely. No, I owe her. She doesn't let me forget it. And, but I do think she's quite proud of where I ended up. So I do owe it a lot to her.
All right, this is being recorded, so she's gonna now have like you saying this on the webinar from now on. Um,
Absolutely.
yeah, tell us a little bit about your journey within AANP, and then and why you took a position of leadership.
Yeah, so I had always, I felt my clinical practice was important to me, and I felt that I was making an impact in my patients' lives. What I also felt was a little bit of frustration, was because I felt there's only so much I can do one on one with patients. So and that was also the rationale for going back and getting my doctorate. I wanted to look at systems. I wanted to figure out how I could best take care of more people, or the health system at large. So I had always been involved. Probably, I was encouraged to join as a student. And associations are wonderful for the professions. And I think a lot of people join because they know they should, but they don't necessarily know why. Unless you're looking for a job, or unless you're looking for some resource that they happen to offer. I knew it was important, but at that stage in my career, I wasn't ready to sort of get more involved. I wanted the experience as a clinician. So always had been a member, and I had been quite involved in my state nurse practitioner association, which is a separate entity from AANP. But I had done a lot at the state level, and I said, okay, how can I sort of have a broader impact? I had become more involved with AANP. I had some friends and some mentors who were part of AANP, and they helped to bring me along, somewhat, punching and kicking the whole way. And But it was great, and I realized that this organization has the ability to affect health policy on a broad scale level, and really impact the profession in a meaningful way. So, I ran for region director, and I was a region 2 director, which was New Jersey, New York, and Puerto Rico. That was my territory. I live in New York. So that was my area. And then I thought that there was more potential, and I ran for president elect. The first time I ran, I did not win. I ran again, and I won. I won that second time. So I've been in this role now. The president's term is 4 years. I did 1 year as president elect. And then in June of 2023, I became president. This is a 2 year term. So I have until June of 2025, and then I'll have one more year as immediate past president. So it's been a journey. There's a lot going on, and it's all good.
That's awesome. And for those of us who may not be as familiar, could you just give us a quick overview on the kind of mission and goals of ANP, and your what your primary responsibilities are, and
Sure.
your focus within the organization?
Sure, sure. So the mission is to empower all nurse practitioners to advance accessible, person centered, equitable, high quality healthcare for diverse communities through practice, education, advocacy, research, and leadership. So we use that PEARL acronym, and everything we do as an organization has that Pearl context. So we're looking at practice, and the practice of nurse practitioners, and research about the profession, not necessarily doing patient research, but research about the workforce. Education, continuing education, advocacy to help us eliminate those arbitrary barriers. that exist out there for NP practice. And then leadership, because we do think it's important for sustainability. Our the nurse practitioner profession now has 385,000 nurse practitioners across the U.S. We've seen really tremendous growth in nurse practitioners from when we were first founded in 1965. And there's a lot going on. And when we think about 1965, so much has changed since then, right? Like when you think about Medicare law and Medicaid law, that's the year that those laws were actually introduced. So we sort of, came onto the scene at the same time, and as a result, there are things that nurse practitioners are not allowed to do due to either state law or federal regulation, and we could get into some of that if the discussion goes there. But that's the mission of AANP. And, we like to say that we are the voice of the nurse practitioner. So we're a professional membership organization representing over 100,000. We have over 100,000 members today. And it's a great organization.
Yeah. You reminded me of something I probably should have said at the very beginning. This is going to be, and you and I said this earlier, super informal conversation, fireside chat. So for the audience members, should you have any questions you want to get into the conversation that haven't already been submitted, please drop it in the chat box, and then our moderators will flag us, and we'll share that question. So thank you for that. And then I just wanted to, I'm reflecting on my own personal experiences with professional societies that I have affiliation with, and sometimes I feel like I can get it feels a little bit distant, right? They're operating on a national level and not necessarily down to me. And there's important work, on both ends, right? So, for a new nurse practitioner who's coming out of their existing role, or maybe even just fresh out of training, I'd love to understand, and I'm sure they would, like how the AANP supports its members at various stages to advance their careers, whether that's
Sure.
at a macro level. I think, and we're kind of touching on that right now in terms of like policy and advocacy, or all the way down to like the granular individual level.
Sure. Yeah. And there's a number of ways that members can interact with AANP depending on where they are in their career. I wish there were more, and I'm working really hard to have more touch points because we are a national organization and we don't have chapters like many other associations do. We work very closely with our state organizations, but we are two separate entities at the end of the day. So let's start with student nurse practitioners, or actually even pre-nurse practitioner students. We have resources available on our website to sort of give a glimpse into what nurse practitioners are, what we do, and really making sure that the people who are entering the profession know what they're getting into. It's my hope that everybody reads those resources. But once someone is enrolled in a nurse practitioner program, there are student resources. First, there's student membership. So there's a discount to join as a student. And there are a number of online educational activities, whether it be precepting or how to be a good, nurse practitioner student when it comes to your clinicals, what questions to ask. And we have a host of resources at that level. As the newer nurse practitioner graduates, is in practice, we have educational offerings. So there's our online resources that we have that is available to members, but we also have conferences. And typically we have a national conference, which we do in June of every year. And we're coming up on that soon. We'll be in Nashville this year. That has just, dozens and dozens, hundreds even of concurrent sessions. So there's ability to plug in there. And then in the fall, we have a conference that's called our Specialty and Leadership Conference, which tends to be education more for the experienced nurse practitioner, and it gets a little bit more into the details. There's a health policy conference that we do in the winter every year. We were in Washington, D.C. earlier this year where we talk all about health policy, and it ends with visits on the Hill in groups, by district, which is a great experience. And those are the sort of the major buckets. Again, there's online offerings, there's practice resources, and I'd like to call attention to what we have are communities. These are online virtual spaces that are divided out by specialty. So, for example, we have an urgent and emergency care one. We have one for occupational health. We have one for entrepreneurs, and members can join these communities and have discussions with other people who are talking about it. There are resources available in a sort of centralized repository that could be downloaded. So lots and lots of offerings, and I am not doing it justice of all the offerings that we have. It is so vast, and if you sort of dig into our website, you'll see just how much is available to the nurse practitioner.
First question came in. So, what's the easiest way for an NP to become a member of the AANP? And if the answer is through the website, what we can do is we can drop that resource in the chat. But go ahead, Stephen.
Yeah, it is. So it's AANP.org is our website, and I would encourage folks to look at us, look at all the offerings and consider joining. I think it's an investment into yourself and into the profession. The monies that our membership dues does not go towards lobbying, because that's separate money. You can't use a certain amount of money. So that's a separate bucket at the federal level. But there's just a lot of resources, and it's really to support you and the profession itself. So AANP.org would be our website.
Yeah, and we'll drop the link. We'll find the connects to it, and we'll put that in the chat. Thank you for whoever dropped that question. And then we have another question that's kind of related. What resources does the AANP provide for nurse practitioners looking to open, own, and operate within an independent entity?
Yeah, that's a great question. I would direct people to our entrepreneur community, where we have experts who have opened up their own practices across the country, and it's a way to collaborate with those folks. We don't have specific state by state because there are so many various rules. And Rafid, I'm sure your organization has some resources, or at least some links that could be useful for something like this as well.
Yeah, I mean, it's like a nice shameless plug opportunity for us. We provide a lot of the resources around compliance and try to support nurse practitioners, obviously, in whatever capacity, whether it's with their own independent entity, which is about half of the nurse practitioners that we support, or they're tied to another enterprise, which is the other half. So, thank you for that opportunity. So let's shift gears a little bit and let's talk about kind of the current healthcare landscape. I think everyone would agree when you're hit with facts that like 78% of the country is healthcare desert. It's not just astonishing, but it's also incredibly sad considering we are a leader in the world. And if you look at where we rank amongst modernized nations, our public health is not that great. So we have an access issue, and I'd love for you to speak on how the role of the nurse practitioners has evolved in recent years, and specifically, what key contributions do you see NPs bringing to the table to the healthcare system in 2024, given the challenges that we face on a macro level?
Yeah, it's a great question, and we know that 70 million Americans lack access to primary care, and it just so happens that the vast majority of nurse practitioner education is based in primary care. So you sort of have this natural way to help lead and fix some of those access issues for patients. And primary care is important, and it's oftentimes the first entry into the healthcare system. And we know, in general, primary care is underfunded and undersupported. not even talking about nurse practitioners, but just primary care in and of itself. When you add mental health access to it, it's a whole nother, it's even worse off than primary care. So we used to lead with the primary care talk, and now it's mental health access is even worse. And there are nurse practitioners who specialize in psychiatric mental health. So, you have these capable professionals that can contribute and fix some of this issue. Now, I don't purport to say that nurse practitioners are the solution to all of the healthcare challenges that exist in our systems, but we are absolutely an evidence based profession that we know that when nurse practitioners are able to practice at the top of our license, that access to care increases. And there is no reduction in the quality of care when that happens. And we have 28 states across the US today that nurse practitioners have full practice authority. And that full practice authority means that nurse practitioners are under the exclusive domain of the Board of Nursing in that state, and they can practice without any written contracts or agreements as a condition to practice. So we have 28 states, and the challenge is that these are laws that are written into the Nurse Practice Act in each state, and every state's Nurse Practice Act differs a little bit. So for RN practice, there's not a lot of variability from state to state as to what RNs can do. But when you talk about nurse practitioners, a type of advanced practice nurse, what we can do with a written contract or without a written contract differs greatly. And the only way to change that is by focusing on those states that don't offer full practice authority and working with those legislators to introduce legislation, get those bills passed, signed by the governor, hopefully, to increase access to healthcare. So it's a very complicated system. We don't have a unified license that's across the U.S. Literally, what I could do in New York differs. The care that I deliver is going to be the same, right? Like, there's no fundamental difference between me as a nurse practitioner in New York and what a nurse practitioner in California can do. But I, in New York, because we have full practice authority, and I have more than 3,600 hours of clinical experience, I do not need to have my charts reviewed. I do not need to have a contract in order to practice, which is not necessarily the case in California. The care that we deliver is no different, but how we get there could vary greatly, and that's part of the challenge for nurse practitioners today.
Yeah, fully agree. I think there's probably a few other differences between a New York NP and a California NP in their stress level as well. if I had to,
Absolutely,
if I had to
absolutely,
venture a guess. Uh, and a related question that came in is how can nurse practitioners contribute to addressing the shortages in healthcare workforce challenges and ensuring access to quality care for diverse populations? So I think you've kind of touched on that a little bit. So just to be specific, I mean, we know the shortages numbers, right? We are projecting to be several 100,000 physicians short in less than 10 years.
mm-hmm.
And we are seeing great growth from both physician assistants as well as nurse practitioners, 8 and 9% respectively year over year growth, which means they'll be doubling soon, right, which is fantastic, right? Is that enough to plug the gap for all the care that we're getting? Not even factoring in like all the people who are retiring and maybe they're taking non-clinical roles, whether they're a physician, NP, PA, whatever, they're
Right.
working somehow administrative, so their capacity is not really fully utilized.
Yeah, it's a great concept, and are we doing the right thing as far as is this going to be enough? And I like to think, and I'm lucky enough to kind of be in a position where I can ponder these types of questions. I really think that when we look at our collective healthcare system, we have to look at it differently. And if we keep doing the same thing, that's the definition of insanity, right? We expect different results. That's insane. So we can't just have nurse practitioners and physician assistants or physician associates, just plugging in uh, where traditionally physicians have been, because there was a reason physicians didn't go or are not as engaged in primary care. And we don't want the same, we want everybody to practice where they want to practice, right? Like that should be the ideal. So I think there needs to be systemic changes in order to have a sustainability in improving the healthcare of our nation, in improving some of these quality metrics, decreasing the cost. We know that the costs of healthcare in this country are so far and above any other countries, and our quality is not at the top. So we need to collectively think about that. But I would also say our healthcare. I would go nowhere else than seek healthcare in this country, if it came down to it, for myself.
As
But
an
I
individual versus a system, right?
Right, as an individual,
Yeah,
the system is a different story, and that's where we really need to focus.
yeah, fully agree. We are going to change gears just a little bit.
Sure.
So I'm going to read directly the question.
Okay.
Great to be here and listening to Dr. Ferrara. Proud to be an international member of AANP and joining from Birmingham, UK. So, question for Dr. Ferrara. Today, our regulator in the UK, NMC, has approved regulation of advanced practice, nursing, and midwifery. What tips do you have as we embark on this regulatory work retrospectively in the UK?
Yeah, I think look at some of the evidence as to the rollout of nurse practitioners, nurse midwives in the United States. What worked from that level. Again, we're going to see essentially 50 different examples. And when you look at advanced practice nurses, right, there are four subsets of advanced practice nurses. Nurse practitioners are the largest, but we also have our certified registered nurse anesthetists. We have our clinical nurse specialists, and we have our nurse midwives. So there are tons of examples in the literature as to what works successfully for that rollout. I think you want to work with regulators at the outset. You want to do a combination of informing them and advising them at the same time, so that they are fully cognizant of what the issues are, to try to anticipate the unintended consequences of any changes. And it really makes sense to do all your homework beforehand before you start going full in. But there's plenty of examples in the literature for that.
Thank you for that. A couple more questions here. We're going to kind of just bounce around, and this is
That's
totally
great.
fine for the
Yeah.
audience. This is great. So we'll move through these. On a community and local level, how can we as nurse practitioners contribute to advocacy efforts for full practice in our restrictive states?
It's a great question. So I would say first up, be a member of AANP. Also be a member of your state organization. Every state from the AANP side has what we call a state liaison. And that state liaison is sort of the liaison from AANP to the boots on the ground in the state. So connect with your state liaison, and every state liaison, there's also a region director. That region director, as I was previously, is responsible for a number of states within that region. That's the communication, and that's how we try to empower nurse practitioners to inform what's going on at the state level. And I talk a lot about health policy to I teach DNP students at Columbia. States legislative sessions differ greatly, right? There are some states that will only pass a bill because they're only in session every other year of a 2-year cycle. So, but that's not to say that that work can only happen in that one time period. Now is the time for those states to do a lot of the groundwork, and I'm not talking just about full practice authority. I'm talking about any issue that has to pass through a state legislature. Is that that work doesn't happen overnight. It takes time. I think the average is about 7 to 8 years when full practice authority legislation is introduced to actually see any real movement on that. So connect with the leaders in the area. There's always something to do, and we realize that not everybody can go to their state capital, right? You can't drop everything and go to the state capital and visit your legislators, and that's okay. There are letter writing campaigns or action alerts. There are other things you can do, short of having to go to the state capital. And we want to make sure that whatever you're ready for at this point in time in your life and your career, that we can plug you in and put your good work to use.
So I'm going to paraphrase and say that you said the government is lazy and inefficient. Is that right? Did I mishear that?
I will neither confirm nor deny
I'll own that
that
one.
statement.
I'll own that one. All right.
Okay.
The next question is: this is going to be reaching back to your regional leadership days
Yeah.
from Jersey and New York and Puerto Rico. How many nurse practitioners practice on the island of Puerto Rico?
Yeah, there's not many. So I believe that number is less than 200.
Oh wow.
And most of the NPs in Puerto Rico are employed through the VA system. There's a VA hospital there. Um, Puerto Rico just recognized nurse practitioners in their state law just in 2015. So not that long ago. And they still are in the process of, sort of figuring out what that means for nurse practitioners. So definitely there is an opportunity there for NPs in Puerto Rico.
What's your take on NP led clinics, and why do you think NPs are reluctant to enter independent private practice?
Um, I'm going to say private practice is hard. I don't care who's providing access to care, but being a business owner is not something that is easy to do. I've spoken with lots of nurse practitioners in lots of different practice settings. Those who are owning their own practice, and those who work for hospital systems, and I think uh, I love the ability to have the options that are out there, but personally, and I say this as myself, private practice to me is quite daunting. You're always on call unless you have somebody that you could share that with. Startup costs are very high. We know that, especially for nurse practitioners, that reimbursement is less than it is for, say, a physician colleague. So I think it's hard. And full practice authority is not about opening private practices. It's about eliminating the barriers to practice. So, yes, there will be a contingency of nurse practitioners who say, hey, I want to practice healthcare the way that I want to, right? I don't want to. I don't want to listen, necessarily listen to somebody, and I want to, provide care that I could see patients every hour, right? That I'm not forced to see patients every 15 minutes, and I say that's great. The challenge with that is making that profitable for you. And I say profitable, meaning that you're not losing money, and that you're able to pay yourself a fair salary. So I think that's part of the challenge with independent practices. I think where we are today, I'm seeing a lot of direct primary care practices that are being started by NPs and physicians, not necessarily together, but in general, because we know that the fee for service model, that is how we primarily get paid as clinicians, is one that incentivizes volume over quality. We are trying to collectively move into value based contracting, but we are so far, at least in my opinion, from that really being a model that you can count on. So I think that's some of the challenges that exist for private practices today.
Yeah, I Couldn't agree more. It's tough no matter who you are, no matter where you are. It's a challenge.
That's
Um,
right.
yeah. So you had mentioned 28 states in the country have full practice authority. So the remaining 22 obviously don't. Um, I'd love to understand the AANP's stance, if there is an official stance, on collaboration or team-based care. Um, and do you see scenarios in which collaboration is essential in addressing key healthcare challenges now or in the coming years?
Yeah, and it's an important question, and I think it we could get confused into mandatory collaboration versus collaboration as
Right.
what we all do as clinicians, right? So when it comes to team-based healthcare, AANP does have a statement on team-based healthcare, and we believe that we look at the National Academy of Medicine that endorses team-based care, but it doesn't necessarily put any one provider as the leader of that team. And we believe that NPs should be able to practice to the top of their licenses. The leader should be the appropriate person that is dictated by the patient's concern and need at that time. May not be a nurse practitioner, may not be a physician, may be clergy, right? For that point in time. And that, we think that, requiring any clinician to be part of a team um, because it's based on your license is not something that AANP endorses. You should be able to practice. You get your license by yourself. You pass your national board certification by yourself. And yes, we will work with others within the healthcare system because nobody can take care of everything a patient of a patient's needs. We need everybody, right? But when it comes to mandating a team, that's where ANP says no. NP should be able to practice at the top of our licenses, and it should be patient centered, and that's at the end of the day what we're advocating for.
So want to talk about the flip side of the coin, right? So what does full practice authority for nurse practitioners mean for patient access? And the context I want to share before you answer is I recently read an article looking at entrepreneurial trends within the nurse practitioner community. And if you look at the areas where there was significant overlap and significant leadership and entrepreneurship, it also happened to be in the places where there was full practice authority, number one. And number two, that also superimposed on, if I looked at a map of healthcare access, there's also
Mhm.
in areas where like access was really lacking, right? So would love to hear your thoughts about what full practice authority means in the context of, not just specifically like access for the patient, because clearly it means more access, but
Right.
is with respect to those two caveats as well.
Yeah, I mean, we've seen in states that have become full practice authority, we've seen the NP workforce grow in that state. Nevada is a great example of that. Within 5 years of passing full practice authority, we saw a 50% increase in the number of nurse practitioners who were licensed in Nevada, and it was because there are more opportunities to take care of patients without having a contract or some other arrangement to take care of patients. We know that full practice authority also addresses health equity. We have lots of patients, lots of nurse practitioners who become nurse practitioners and go back to work in the communities that they were raised in, and are able to give back to their community in by practicing. And we know patients have a preference for that. Patients feel more comfortable. So it's very much has a lot of upsides to it. I know that there's been scant criticism that nurse practitioners end up practicing where physicians are, and I don't think that that's true. I know that there is data out there to support that NPs are in underserved communities, and I'm not making this one profession versus another, but these are some of the criticisms that I've seen. It's that there are a number of states that had mileage requirements that a nurse practitioner couldn't practice outside a certain mileage limitation from their collaborating physician, which makes no sense, right?
That doesn't make sense.
So I think there's a lot of variables into that, but we are able to look at the workforce and see that workforce increases when there's full practice authority, and patient access increases as well. So it's not coincidental there.
So, question in the chat here, and I think it's one that, I mean, you've kind of alluded to it, around like some of these, like not controversies, but where the pushback exists, specifically as it pertains to full practice authority. In my experience as a preceptor for NP students from several NP programs, NP training NP training programs are not standardized to the extent that medical schools and residency training programs are. You mentioned the quality of care does not suffer in full practice states. Is there any particular data that this is based on? And I know you and I have had previous conversations about kind of variance in types of programs and training. So I'd love to hear your thoughts here.
Yeah, so I will say that there is work to do. When it comes to all health professions, and I say nurse practitioners are need some looking at as well. I do think that we have a preceptor access problem when it comes to nurse practitioner students, and look, AANP supports. Accredited nurse practitioner programs, nursing programs, right? So, if you're not an accredited program, you should be going to an accredited one. So that's first and foremost. And there are standards that they follow. They differ than medical school because we're not going to medical school. We're going to NP school. So, I think that there needs to be an investment in work for preceptors and to find students quality preceptors, and AANP hears that, and it's one of my personal agenda items that I want to see improve. So we are actively engaging with lots of different stakeholders to that degree. And as far as evidence goes, I mean, there's no evidence. Um, the evidence that's being published in peer-reviewed articles, in peer-reviewed journals, shows no lapse in the quality of patient outcomes. It's not there, right? It may be there at some day, but it's not there now. And I think we work very hard. Every nurse practitioner I know wants to take the best care of patients that they possibly can. But there are challenges in the system, and I want to make sure that we're addressing that. The other thing I want to just make it explicitly clear is that AANP is not an accreditor of NP programs. So we have our space, and of course we speak with those accreditors, but AANP is not the entity that is saying NP programs must do X, Y, and Z. That's again, we can talk to people, but if it's something that we were able to control, that's a different discussion. But that's where we are, and I think AANP, as a large of an organization as it is, gets a lot of well, not a lot of, but some people say, well, AANP should do X, Y, and Z. And, it's just not within the domain. If it's not possible within this organization, what we can do is build consensus and speak to those folks who are responsible for that to help elicit whatever we want to happen.
Yeah, I think the challenge is the scope of influence is here, but the scope of responsibility for
Yeah,
A and B is here, and you can't control all these other variables.
that's right.
Um, and it's interesting because you have to advocate for everybody, regardless of regardless of
That's
how they've gotten there, if you have differing opinions. So
that's right.
it's an interesting challenge for the A and P.
Sure is.
I can imagine. So, just a quick time check. We've got about 13 minutes left. We still have a few questions to get through. So, if there's anyone in the audience who wants to submit your questions, now is definitely the time to do so. One more question for you, Dr. Ferrara,
Sure.
regarding discussion around healthcare access problems. What's your take on hybrid or virtual care only, often called like bricks and clicks or virtual first care? Should virtual health solutions be pursued aggressively, or is there a limit to how much of a solution this can provide?
Personal opinion, and I preface it with that. I do think virtual telehealth, or whatever we want to call it, I think there's a role for that to play in the provision of healthcare, without a doubt. Can it replace in person? I don't think so yet. At least with the technology that we have. So, I think we need to explore the possibilities when it comes to virtual formats. But at the end of the day, I think that we still need to have, in certain situations, clinicians lay hands on a patient to examine that patient. There's a lot we can do virtually, and I'm not minimizing that. But I do think that there should be a healthy mix of what we can do virtually versus what we could do in person. And that's a challenge. With the pandemic, we saw telehealth explode because it was the only way to access care. What created lots of problems was that, again, when you're a nurse practitioner in New York and you're needing to see a patient virtually in, say, Tennessee, they have different state laws. You just can't do that. You have to follow that state law. So that's where telehealth gets very messy. I know that there are efforts at the federal level to help address that. And I think it also comes down to, again, is back to my payment comment, is that the reason why telehealth exploded, in my opinion, during COVID, was because it was paid for the first time, really, in earnest, right? So now it's paid for. Clinicians will say, well, I'll do it now if I'm going to get paid for it. So what's the right mix, right? What makes sense from a telehealth perspective versus in person? I am sure that you can't be at either extreme, and that you have to be somewhere, reasonably in the middle.
Yeah, I have this. I feel like when we have a new technology, whether it's like years ago was kind of like blasted on the scene, or now the sexy new thing is AI, everything AI related. We think it's a panacea as soon as we first get it. We're like, oh, this solves all of our problems, and then we realize actually it solves like this much of our problems, but it's still good. It's still better than
It's
zero.
still good, right? It's another tool. It's another tool that we could potentially use, and it hopefully is helpful. But it can't just replace. You can't just throw it all out and start from scratch.
Yeah, yeah, agreed. Um, on this kind of similar subject of education, what role does education and continuous professional development play in preparing nurse practitioners for the evolving demands of their roles?
Yeah, I think anyone going into healthcare has to be understanding that there is continuous learning. There are new treatments being developed. There is new evidence being gleaned, and we need to be cognizant of that. You can't possibly practice the same way that you did 20 years ago than you do today. And that's why we have opportunities to go to conferences and bring back some of that best practice and that information. And it has to be any healthcare provider's mentality that data will shift, evidence will change. How does that affect the art of my practice and the impact it's going to have on my patients? So I think continuing education is critical. I mean, look what we've done throughout COVID, right? Like, just knowing where we started with COVID, which there were certainly people at the beginning saying it's airborne. And then I think even today you have some controversial people saying it's not. So that aside, we need evidence, we need data in order to make decisions when it comes to taking care of another human being, because that's what we're doing at the end of the day. And
Yeah.
you could look at lab values, you could look at blood pressure values, but a lot easier than trying to fit that into the complexity of a human being and what's going on in their life and what do they have access to or what don't they have access to. And that's where we really need to be able to speak with our patients. You're not going to do that in 10 minutes, right? You're going to do that through knowing what who that patient is and where they're coming from. So it's not easy, and it shouldn't be too easy to take care of another person. And that's why we're committed with the ongoing education and the recertification and whatever metrics are in place to ensure high quality outcomes.
Yeah, I tell my residents and my mentees, it's always good to be a little bit nervous about your performance. So you double check and triple check just to make sure that you're staying at your best game, because everything, it's the ground is moving underneath your feet right now. There's so
Absolutely.
much new data coming out.
That's right.
Um, so, a question kind of combining two of the most recent questions around education and also technology. With advancements in technology and changes in patient needs, how do you envision the future of healthcare for nurse practitioners? And what skills or competencies do you believe will be crucial for NPs in 2024 and beyond? And this is a conversation that comes up, I think, at every professional stakes level. Like, I hear this a lot. It's like, how do you evolve with the technology? So, I'd love to hear your take on it.
Yeah, well, I think nurse practitioners need to be aware of what's emerging. And again, I think that when you are taking care of your patients and that's where your focus is, you need to look outside and say, okay, there are some new things emerging, and I need to be aware of it and how it's going to impact my patients. And patients are savvy today, right? They're hearing what's in the news, and they're hearing reports of, and this is where I think it can be a little challenging as a clinician, where you hear about this breakthrough treatment that has been not FDA approved yet. It's coming down the pike. Patients are going to want to ask about it because they may have something that they're invested in. So we have to be aware of it, and that takes time, right? There's nobody forcing you per se to know this information, but if anybody is, it's the patients, right? It's patient care. So I think you mentioned AI, Rafi. I think there's a lot to AI. I am hopeful with AI. Of course, there's concerns with it, but I personally want to see AI take away the documentation burden from clinicians. And so when I'm spending that 20 plus minutes with a patient, I don't have to turn to my screen and type something, right? Like I'm waiting for the day where that's going to be accurately captured, and I can review that note generated at the end and be able to focus exclusively on that patient. So I think that's critical. Moving forward, I think it's the understanding again that practice is going to change, guidelines are going to change, be updated, and it's incumbent upon any practicing provider to know what that is and how to best care for that patient.
Yeah, I couldn't agree more. And I think, this idea that we can resist, or the market forces, is probably silly, and like we should just ride the wave and use it to our advantage, right? At the end of the day, the visible stakeholder is the patient, and so to
That's
the
right.
extent that we can make that, like, have a much better experience, that's always the goal. I think when I talk to other colleagues, I think the big thing they fear is, it's like, oh, because everyone agrees with what you said about, like, we spend way too much time doing non-patient facing activities,
Right.
and once we eliminate, like, we've made that 60% reduced down to like 20%, we're
Hmm.
not going to get that 40% time back. They're going to be like, okay, well, here's more patients to see in that time period.
Right. Right.
Yeah, so we have to figure out kind of a comprehensive solution. As we're coming up on the end here, so I want to throw one more question at you. This is going to be my shameless plug for AANP. We're obviously big supporters of the organization. Can you talk to us about some of the priorities, the top priorities for 2024?
Yeah, that's a great question and a nice one to end on. At the federal level, there is legislation called the ICANN Act, which stands for Improving Care and Access to Nurses. And this is an omnibus bill of sorts for Medicare. And it includes things like NPs being able to be assigned in accountable care organizations attributed for patients, which we cannot be right now. There's a cardiac and pulmonary rehab condition that inpatient nurse practitioners cannot authorize because of outdated language. And my favorite is diabetic shoes, right? So nurse practitioners, unless you are the only NPs that could write a prescription for diabetic shoes and have Medicare cover that, is for NPs that are in ACO REACH plans or arrangements with accountable care organizations. But otherwise, an NP, regardless of the state that you are licensed in or living in, cannot write a prescription for a patient with diabetes that has Medicare, and Medicare will not pay for those diabetic shoes to be, given to them by a diabetic shoe supplier, because the law, Medicare law, which is federal, doesn't recognize nurse practitioner signatures on that. So again, it seems like such a small thing, but think about the potential of how it's affecting patients, and what the way to fix it is through Congress, and it has to be signed by the president, right? So this is not an easy task, and this is a federal priority that we are focused on. And the other areas that AANP is focused on, again, is improving the workforce, providing solutions for the practicing nurse practitioners, making sure that NP students have the resources that they need to be successful, and all the other things in that Pearl acronym that I mentioned before. But there's a lot to consider. I invite anybody who wants to be more involved with AANP or any questions to reach out to me. I'm accessible on LinkedIn and social media. And I like to think, and this is corny, and I will end with this corny statement. My intention is to leave this profession better than when I started. And if there are things that I can do to improve it so that we can take better care of patients or to improve healthcare outcomes, well, I can say I had, I put my best foot forward, and I could say I did a little bit of that.
I think everyone says that, but significantly fewer actually walk the walk. And it's an absolute pleasure to have hosted you, Stephen. Dr. Ferrara, you're a great leader in the space and an ally for us, and we're big supporters. So thank you for making time. Thank you, Goldstein Friedberg, for sponsoring this event. And we will give everyone some time back. Oh, actually, we're a minute over. So
Cool.
thank you for the extra minute. All right.
All right. Thank you. It was great. It was my pleasure. Thank you so much for having me, Rafi.
Thanks, Stephen. Take care.
Thanks. Bye-bye.